All right, so this is going to be Module H Integumentary system, and we are going to talk about the skin, which is the integumentary system. This is actually the largest organ and system in the body. It includes accessory structures like hair and nails, and it's responsible for providing a natural protective covering of the body. Our integumentary system, our skin, is made up of 3 layers. You've got the epidermis, the dermis, and the subcutaneous or fatty tissue. The epidermis is our outer layer. So this layer has living and dead cells. Those living cells push the dead cells up as they divide, and those dead skin cells flake off. Living cells contain the pigment that give our skin its color. There are no blood vessels and only a few nerve cells in this layer of the skin. The dermis is the inner layer. It's made up of connective tissue, blood vessels, nerves, sweat glands, oil glands, and that's where our hair roots are located as well, as you can see in this image. The subcutaneous or fatty layer is the thickest layer, and it's a thick layer of fat and connective tissue. The integumentary system protects our body from injury and pathogens. It regulates our body temperature. It eliminates waste through perspiration, and it contains our nerve endings that sense cold, heat, pain, pressure, and pleasure. This is also where we store some fats and vitamins. Under normal conditions, we expect our integumentary system, the field, to be warm and dry, to be absent of breaks, rashes, discolorations, and swelling. As we age, things do change with our integumentary system. Our skin becomes thinner, drier, and more fragile. It also loses some of its elasticity. That fat layer decreases, which is why oftentimes as we age, people feel colder. So you may see, Grandma Betty in the nursing home, and she's freezing, even though it's 78 degrees and we're burning up. And she's got, a beanie on and is covered in 3 blankets. Also, our hair thins and it may turn gray. In addition, we're going to see those folds, lines, wrinkles, and sometimes brown spots that may appear. Our nails, you may have seen this, they become harder and more brittle. We also have reduced circulation to the skin, which is what causes that dryness and itching that you may see in the older adult. And sometimes we will develop skin tags, warts, and moles as we age. Now, those are all some normal changes that come along with aging. Now, when we see these variations from the normal, these are things that we want to make sure that we're reporting to our nurse. If we see breaks in the skin, pale, white, or reddened areas, which could be a sign of a pressure sore, black or blue areas, or changes of the hair and scalp. If we see rashes, itching, or new skin discoloration, if the skin feels abnormal to touch and temperature, right? Too cold, too hot, clammy. If we notice swelling, ulcers, sores, or lesions. Now we said drying can be a normal change of aging, but if we see excessive drying or flaking of the skin, that's something to report, or fluid or bloody drainage. And now let's talk about a few common things that you may see as they relate to the integumentary system. Shingles, which is caused by the Herpes Zoster virus. It's the same virus that causes chickenpox. This virus is inactive in the nerve tissue, but can become active down the road years later. And it's most common when we're talking about shingles in particular, it's most common in people over the age of 50. Some signs of shingles are rash or blisters that are on one side of the body, and most people report this as a burning pain, a burning sensation. Sometimes they'll have numbness and itching, and usually this will last for about 3 to 5 weeks. The CDC states that the following should avoid contact with infected residents. If you have never had chickenpox or the immunization, avoid someone with shingles. If you have a weakened immune system, or if you are pregnant and never had chickenpox with immunization, avoid taking care of those residents who may potentially have or do have a shingles infection. When people have shingles, they're considered infectious until those lesions crust over. So our role as nurse aides is to follow the care plan, keep that rash covered until it does crust over, and remind residents how important washing hands is and also avoiding scratching those areas. The vaccination is recommended for people 60 years or older who have had chickenpox in the past. Stasis dermatitis is another condition you may come across. This is a condition of the skin affecting the lower legs and ankles. It occurs from a buildup of fluid under the skin, and it's a problem with circulation that results in fragile skin that can lead to wounds and ulcers. Early signs of stasis dermatitis include scaly, red, itchy areas, and later signs as this has progressed, you'll see swelling of the legs and ankles or other areas. The skin will become thin and dark, and it will be painful. So as nurse aides, we want to report any of these signs and symptoms that we may be seeing and make sure that your residents or your patients' socks or stockings are not too, or shoes for that matter, are not too tight. And if we're noticing any of these things, making sure we're reporting it to the nurse. Knowing that part of this patient's treatment might include the anti-embolism stockings and elevating the feet regularly. Now, when we learn how to put on these compression stockings, and we'll do this as one of our skills in class, these do compress, but when they're worn properly without wrinkles or folds or twists, they're not going to cause pressure sores. If they're put on improperly, with this swelling additionally, we can cause pressure sores. So keep that in mind. And speaking of pressure injuries, the Centers for Medicare and Medicaid Services defines a pressure ulcer or pressure injury as any lesion caused by unrelieved pressure that results in damage to underlying tissue. And friction and shear are factors. The CMS requires that long-term care facilities identify residents who are at risk for pressure ulcers. Many pressure ulcers occur within the first 4 weeks of admission to the facility. It's important to know where the bony prominences are because bony prominences are areas where the bone sticks out or projects from a flat surface of the body, like the back of the head, shoulder blades, elbows, hips, spine, sacrum, knees, ankles, heels, and toes. So these are areas where we are more likely to have pressure injuries. And they mention shear and friction. So what is that? Shear is when layers of the skin rub up against each other, or it could be when the skin remains in place, but tissue underneath is moved and stretched, causing damage to the capillaries and blood vessels. An example of when this could happen is when we're moving someone up in bed. Friction is the rubbing of one surface against another, essentially when your skin is dragged across another surface. Again, another instance when this can happen is when we're moving patients around in bed, transferring or moving them up. The CMS has defined 2 other terms, unavoidable pressure injury and avoidable pressure injury. An unavoidable pressure injury is one that happens despite all of our efforts to prevent a pressure injury through proper use of the nursing process. So we've done everything we can, including, changing position and repositioning every 2 hours, but this pressure injury has still happened. An avoidable pressure injury is one that develops from improper use of the nursing process, basically when we're not doing our job to prevent pressure injuries. There are risk factors that contribute to a pressure injury. Pressure is the major cause of pressure injuries, of course, but shearing and friction, like we mentioned, are contributing factors. All of these things contribute to skin breakdown. But other factors that can contribute to pressure injuries include immobility, breaks in the skin, poor circulation to whatever particular area it is, moisture, for example, someone being incontinent, excessively dry skin, and irritation from urine and feces. Older residents and disabled residents are at risk due to skin changes due to aging, also chronic disease, and just being more frail. Residents who are bedfast, which means they're confined to the bed for various reasons, are at more risk. anyone who requires some or total help moving, for example, someone who's in a coma or paralyzed or who has a hip fracture, agitated residents, or those who have involuntary muscle movements are more at risk for pressure injuries, those with urinary or fecal incontinence, those who are exposed to moisture, poor nutrition or poor fluid imbalance, lowered mental awareness. If your resident has problems sensing pain or pressure, like they may have some neuropathy. If they have circulation problems, if they're older, obese, or very thin, if they refuse care, or those who have a history of pressure injuries are more likely to suffer from pressure injuries in the future. Now, pressure injuries are categorized by stage. Stage 1, you have intact skin still, but there is redness over the bony prominence. Stage 2, this is when you begin to have skin loss. You may see a blister or a shallow reddish pink ulcer. And in this stage, the blister may be intact or it may be open. Stage 3, this is considered skin loss, full thickness, the skin is gone. You usually see some of that subcutaneous fat layer. You may see slough, which is dead soft tissue. It's often moist, but it can vary in color from white to yellow, green, or tan. This may or may not be present. Stage 4, this is full thickness skin and tissue loss with muscle, tendon, and bone exposure. That slough or eschar may be present, and often you're going to see a black or brown color as well. Sometimes these pressure ulcers are unstageable. And these are considered full thickness tissue loss with injury covered by slough and or eschar. Deep tissue injury is when you have purple or deep red. It's localized to an area that you may have intact skin or blood-filled blisters. These deep tissue injuries are usually due to damage of underlying soft tissue from pressure and or shear. Forgive me, I think I misspoke a little bit. Let me back up a tiny bit. So stage 3, that's when you may see that some skin loss, and you may see the subcutaneous fat, and you may see some slough, but it might not always be there. Stage 4, I think I skipped ahead a little bit. Stage 4 is when you're going to actually see the muscle, tendon, and bone exposed. So I apologize. I think I categorized that with stage 3. So stage 4, again, as you can see in this image, that's when you've gone all the way down to the bone layer. Stage 3 stays within that subcutaneous fatty layer. Let me know if that was confusing. I apologize. I skipped over that on accident. So pressure injury, again, occur over these bony areas called pressure points and can include any of these areas in this picture that we mentioned. Objects can also contribute to pressure injury, so that's really important to keep in mind. This could be something from their glasses for that they wear to see, to oxygen tubing, to casts or braces. If someone is obese, they can actually even have pressure areas that occur where skin comes into contact with skin, such as abdominal folds, legs, buttocks, thighs, or under the breast area. So when we're talking about pressure injuries, prevention is key. We have to identify residents who are at risk. Measures are directed at handling, moving, and positioning residents and providing skin care frequently. When we're talking about handling, moving, and positioning residents, we want to make sure that we follow the care plan, follow repositioning schedule. Again, it's going to be at least every 2 hours or more often as needed. We want to make sure we're using assistive devices like pillows, foam wedges, and supporting the feet properly, like we mentioned in a previous lecture. Sometimes that's floating the heels, for example. We never want to position our residents on an area that's already red or already has a pressure injury. We also don't want to position our residents on tubes or other medical devices. We're always wanting to prevent friction and shear and keeping, again, like I said, the feet and the heels elevated off the bed. When someone is in the lateral position, to prevent this friction and shearing, we want to make sure the bed is not raised more than 30 degrees and pillows are placed under the head, shoulders, and legs. This position is going to prevent that friction, that shear. And person does not lie on their hip as with the side lying position. So when we're in this lateral position, it kind of keeps some of the pressure off the hip when we use these assistive devices to, again, prevent that pressure that could be on the hip if they were in a full side lying position. All right, we want to make sure to provide adequate skin care. Anytime we're working with our residents, we're inspecting the skin. We want to make sure that we follow the care plan for bathing. If we use water that's too hot or a cleansing agent that's too drying or irritating, this can cause skin breakdown. If someone is incontinent, we're wanting to clean them, as frequently as needed and as soon as we can. If there's any kind of wound drainage, we want to be aware of that. If someone has really dry skin, we do want to keep it moisturized. We don't want excessive moisture, but we do want to prevent excessively dry skin as well, because that can lead to more skin breakdown. We can give back rubs when repositioning, but we want to be careful not to rub over bony prominences. We want to always keep linens clean, dry, and free of wrinkles, because believe it or not, if someone has a lot of high risk for pressure ulcers, even a little wrinkle in a bedding can cause pressure sores. We want to avoid vigorous scrubbing when we're bathing or drying our residents. Avoid skin-to-skin contact by using pillows or blankets, and do not put heat directly on a pressure injury. And that concludes that section, the integumentary section. If you have any questions, let me know.